Hello.
Yeah, hi, Dr. Jan. Welcome. We are starting.
Yeah. Yes, please.
Okay. Uh, so I think we can start now. Uh, you just you're gonna play a short video, and then we'll get started. May I request the admin to play the video, please?
Powering through helplessness, working long hours, all anxiety and distress, leaving behind their loved ones to keep the heart beating of those near to us. Their service is unparalleled, their efforts are unimaginable, and their contribution is incomparable. Let's come together. Let's thank them for what they do. Heroes, saviors, and guardians of our lives. Dear healthcare workers, we thank you. मुझसे पूछे घर कहाँ क्यों मुझसे आके दस्तक पूछे दर कहाँ राहें जिनकी मंजिल है नहीं ढूंढो मुझे अब मैं रहता हूँ दिल है कहीं और धड़कन है कहीं सांसें हैं मगर क्यों जिंदा मैं नहीं
Well, thanks for that very touching video. Uh, I would like to extend a very warm welcome to our very prestigious panelists here, whom I'm going to introduce in a minute, and all our audience. We have attendees I can see from all over the world. So thank you everyone for your time. And as I was reflecting upon the, the sort of happenings of the last 15 to 18 months, it's sort of been a journey, right? A very, very intriguing journey for all of us, if not most of us. We've seen the uncertainties and the fears of the early 2020. We've seen it building up into a peak, the panic and the lockdowns. We've seen the hope and the recovery. We've seen people getting careless, and we've seen the second wave catching us with a very nasty twist. We've seen suffering all around us. We've seen our friends, our families suffer. We've seen our colleagues in the medical community, put in their best and work 24 hours a day. So salute to them and to some of the doctors and other members of that community who are present here today. Reflecting upon all that, we thought, I think we as a society in general have gone beyond the basics. I think we don't need to talk a lot about what COVID is, what is the pandemic about, what kind of symptoms, what kind of issues, what to watch out for. Perhaps it is time to move forward, to look at things beyond that, to understand from the experts what they've seen, what they're seeing, and what they anticipate in the future, and perhaps a few lessons that we can get from them. So the whole idea of today's session is to hear from these experts who've seen this pandemic, who've seen those patients, who've seen the medical processes, the medicines at work, and what works, what doesn't work. So that's sort of, hopefully, if all of us can take away a little bit of lesson from this session, I think it will be very valuable. What I would suggest to the attendees is that in interest of time and maintaining a flow, we would like to ask some pre-specified questions to these three guests. For other questions, we suggest that you feel free to type in your questions in the discussion chat area, whether you are here on Zoom or on YouTube, and the admin will take note of your questions and we will try and consolidate and ask some of those questions towards the end. Without much ado then, I would say let's get started. Let me introduce our panelists very quickly, and then we'll get on to the questions and answers. It's my great privilege to introduce the three panelists to you. First of all, I would like to introduce Dr. Ashish Jain. Dr. Ashish Jain is a senior consultant at the Department of Pulmonology in Max Super Specialty Hospital, Saket. He has more than 20 years of experience in respiratory medicine. He specializes in interventional bronchoscopy and thoracoscopy, including endobronchial ultrasound. He's been awarded and endorsed by the European Association of Bronchology for his extraordinary work. And he's been deeply involved in treating the patients in one of the most sought after hospitals in Delhi. He's handled thousands and thousands of cases in the last 1 year. I don't think he probably remembers how many cases he's seen and helped resolve. Okay, so welcome, Dr. Jain. Next, I would like to
Thank you, Ron.
welcome Dr. Anuradha Wadhwa, MD, FASN. She is practicing medicine for over 20 years in US. She is a recipient of Distinguished Service Award for VA Kidney Disease and Dialysis Program. She is founder of Chicagoland Kidney Support Group and teaching honor role for Loyola Medicine Program. She is a Medical Review Board member, ESRD Network, and National VA PD Work Group Core Committee member. Thank you, Dr. Wadhwa, for being with us and sparing your time.
Thank you.
Next, Dr. Deepti Chauhan. Dr. Chauhan graduated from Russian National Research Medical University and has 24 years of diverse experience in the medical field. She presently works in Oak Park, Illinois, and also practices at VA Hospital Maywood and Burridge. She specializes in internal medicine and infectious diseases. Dr. Chauhan, pleasure to have you here, and we are looking forward to learning from your very relevant background and your experience here. Okay. I think with that, we should probably start the question and answer session. Given that we have doctors from the US, and US has seen a fair bit of its own suffering. Of course, there was a time that US was the most impacted country, though we are catching up, or we caught up very soon in India, unfortunately. US has seen a peak of 300,000 plus cases per day in January. And then the numbers are, of course, today they've whittled down. They are less than 30,000 per day. So what would be interesting to hear from you, Dr. Wadhwa, as we've seen it from very close quarters. What is the reason for such drastic drop, and how did you guys manage it? It will be a good learning for all of us.
Yeah, that's a great question. So you're right. We did see another peak happening early in the year, and that's what we were seeing from the cases due to the holiday season towards the end of the year and the New Year gatherings. But since that time, the number of cases has continued to decline. And we are at an average 7-day positivity rates of 3% or so, which is really low compared to where we were earlier. Now, the key thing that we attribute a big part of, where we are from where we were earlier is around the same time in December, the vaccination program in US started. And there was a huge emphasis, to get the vaccination out there to the community. The big emphasis was initially in the older population because those are the people we saw have the highest mortality, and the hospitals being filled with those patients when we had these peaks. So as of most recently, more than 70% of all Americans over the age of 65 have been vaccinated. Roughly 45% of Americans over the age of 18 have been vaccinated. So overall, we are roughly at having vaccinated half of our population at this point in time. When I say fully vaccinated, we mean the 2 doses for the Pfizer and Moderna and the 1 dose for Johnson & Johnson vaccine that we have available. And the goal is to get this roughly 48, 50% to almost 70% of the adult population being vaccinated by 1st of July. Now, with the vaccinations, we have seen the cases drop, the COVID cases go down. We've seen the hospitalizations go down. We've seen the number of deaths go down. So it's really giving us a very good sense of optimism. So in addition to continuing to follow the universal precautions, which should be followed, the hand hygiene, masks, social distancing, environmental disinfection, I think vaccination has been the key player here, which has resulted in the number of cases that we have seen go down in the last few months.
Sure. Thank you, Dr. Vadrasinghe. It seems like broad vaccination and quick vaccination is the key to where US finds itself. And of course, I think it sort of took a little bit of time to react, maybe political reasons, maybe whatever, but I think it's sort of caught up and now again leading the world. So it's very great to see. Dr. Jain, unlike the US, we seem to have played the inverted wave, right? We were so comfortably placed in January, and when we all thought that we'd sort of gotten over it better than most countries in the world, at 10,000 or less, daily positive cases in January, here we are today, having crossed 400,000 positive cases in first week of the month. So what do you think has gone wrong here in India?
Well, almost everything. Right from the society, right from the general public, the society, the political establishment, the administration, everybody thought that that sense of euphoria was there, that hey, we have done it and we are here now. We have taken care of this COVID wave, but unfortunately, so therefore we lowered our guards down. There were people waiting to go to the marriages. There were people who were waiting for going to their workplaces. The industries were opening slowly and gradually. So that commotion, that chaos started, and plus then we had religious festivals, and then we had these political rallies, big political rallies. So people started focusing on that. So that was one thing, and the most important second thing is that we knew that it was coming and we did not act on time. Probably that was the big mistake that we made, and we paid heavily for that. And plus the vaccination program, it started off well, but it could not cover the, because of the huge population, it could not cover the desired numbers. That was the other reason, probably why we are where we are right now.
Sure. Dr. Jain, it sort of seemed like that Indians had a special blessed gene, and that we handled the first wave very well, and that the infection rate was lower despite, not so great an infrastructure awareness. But what do you make of this second wave? It seems that the virus has mutated, the double mutation, it seems to be highly contagious. The mortality seems to have gone up. I don't know whether it's because of the virus or because of the creaking infra with the sort of the huge pressure that it had to face. But as a doctor, having handled thousands of such cases, right? What was your experience? What are the takeaways for you from this sort of almost flooding of patients?
Yeah, so definitely this second wave, the mutant virus is more lethal than the previous one. That is one definite thing, and in fact we were seeing it coming, even from the US and UK experience, that this wave is going to be more lethal. So since the patients were more severe, they required more oxygen, they were getting sick more early as compared to the previous wave, and this time the younger population was the one who got affected most. I think these were the reasons that everybody rushed to the hospitals. The hospitals got filled very quickly. There was paucity of oxygen for a few days before it was handled. And that was the reason for the high mortality. The overwhelmed the entire hospitals and the entire medical infrastructure got overwhelmed with the kind of huge numbers of patients coming to the hospital. And that, apart from the lethal nature of the disease, apart from the lethal mutant virus, the inability of the medical infrastructure to handle all these patients was also responsible for so many deaths.
My next question is to Dr. Chauhan. Dr. Chauhan, with the, since you specialize in infectious diseases, I thought it would be great to hear your views on this. I mean, from the beginning of the pandemic, right, we heard about the primary mechanism of spread being, droplets, and therefore a reasonable amount of social distance coupled with hand hygiene should do the trick, right? And so it was all about using soap and sanitizers, and that's about it. And then gradually the narrative changed from there to, oh, perhaps there's aerosol-based transmission in air. You want to maintain at least 2 meters distance. Off late, we are hearing, look, you don't know, it may be airborne and it may hit you even 10 meters away. Now, obviously, there's a plethora of information and we are all thoroughly confused. So what's your view as an expert, and what's really the best way for us to protect ourselves? What's your message to the public?
Sure. So essentially, there are 3 modes of transmission of the virus. First is by inhalation of the virus. So basically that happens when a person is infected and with the virus, and the person is releasing the virus when they talk, when they breathe, even quietly, when they're speaking, singing, exercising, coughing, sneezing. So the virus is released in the form of droplets. So there are large droplets which settle down with gravity onto the surfaces. Then there are the small, very, very minute, fine droplets, which basically, along with the aerosol particles, these droplets, they rapidly dry in the air and they remain suspended in the air. And that could be from minutes to hours. And the concentration of these minute, very small droplets, it increases where the patient is and around that area. But when the patient is there for more than like 15 minutes, for a longer time, and especially in poorly ventilated spaces, the concentration of these droplets, it increases. And that's why another uninfected person, if he or she comes in that area, the chances of getting the virus becomes higher. So also the viability of the virus also depends on the humidity, the temperature, and how long the UV rays, which is the sunlight, and how long the virus has been there. The second way the virus can get is into us is deposition of the virus onto the exposed mucous membranes. So like on the mucous membranes of the mouth, the eyes, the nose. And this can happen when a person is even talking or sneezing, getting splashed. The third way you can get the virus is by touching the mucous membrane with your soiled hands contaminated with the virus, or touching inanimate objects where the droplets have landed, and then touching your eyes, your mouth, or your nose. So the best way to protect yourself is universal precautions, which is wear mask, and that decreases the transmission for sure. And the mask should be snugly fit. It should cover your nose and your mouth both. And another way to do it is using eye protection, wearing shield, glasses, and diligent hand washing, social distancing, like you said, remaining 6 feet away, at least. Avoid crowded spaces, especially poorly ventilated spaces. Avoiding close contact with ill people, and wearing like the personal protective equipment, PPE, when you're around them, which was what I mentioned earlier. Quarantining yourself for at least 14 days is preferred per the guidelines, but you can make it shorter, down to 7 to 10 days if you have had viral tests done within 48 hours of discontinuing the isolation after at least 6 days of infection. And then the most promising approach is the vaccination, like Dr. Wadhwa talked about, which has really helped us in curbing down the infection in the US. So those would be my recommendations.
Well, thank you. Thank you for a very comprehensive answer, Dr. Chauhan. The next question is for Dr. Wadhwa. Of course, this is a topic of much debate. Do you have recurrence of infection or not, right? We understand that there isn't enough data. A lot of studies need more time. We do not know whether whatever antibodies get produced, they are sort of enough to prevent a quick second recurrence. Are the emerging strains going to cause a problem in terms of whatever previous protection you have, et cetera, et cetera? But what's your view, Dr. Wadhwa? What does the data suggest? Are you seeing sufficient evidence to suggest that reinfections are frequent and quite possible, or is it an exception? What is your take?
Right. So again, that's a great question. And as you mentioned, for the reinfection, there's not a lot of data because we still probably have a lot more learning to do, but there are two main studies that are usually cited and quoted. One of them being a smaller study with, I think, roughly 3,000 Marine recruits, where they were followed for a short period of time, and they saw, they had people who were positive before, about 200 in the study out of the 3,000, and the remaining were negative, and they followed them over a several weeks time period. And they saw an incidence rate of about 0.2%. The other one was a larger study from UK, where they had about 25,000 participants, out of whom 8,000 actually were positive at some point in time, and the other 17,000 were not. And then they followed them for several months, about 6 months or so. So what they showed was that a previous infection resulted in roughly 80% lower risk of reinfection. And the average protective time based on that study was 5 months following the initial infection that we have. So the bottom line is a previous infection with COVID does not guarantee an immunity against a subsequent infection. The risk of reinfection may be lower, even if it's less than 1%. But if we translate that to our population in India of more than 1 billion, that 1% or even lower than 1% can be a significant number of patients over time. And much remains to be seen what will happen in fall, like 6 months from this peak. That's when we will really know. Hopefully we would, have made much more progress. Now, in addition to the reinfection, what US has also been trying to look at is breakthrough infection after the vaccine, because that's another question that comes to mind. So, as of about a month or so ago, they looked at almost 95 million people who were fully vaccinated in US, and about 9,000 of them had a breakthrough infection, which is 0.01%. So much smaller number for those who had the vaccine before in terms of a breakthrough infection. And majority of these patients were either asymptomatic or had very, very mild symptoms for their infection. So again, I think we cannot emphasize or underscore enough the importance of mass vaccination, because although people are getting infected now, vaccination will still be our way to prevent ourselves from getting into the same situation again.
Sure. And I'm guessing, Dr. Wadhwa, that while the probability of getting a reinfection is lower as compared to fresh infections, people still can carry infection, be a fomite, for example, and therefore they should always be careful. Even if they've been infected, doesn't mean they can't, carry an infection as a fomite. So yeah. You also touched upon on sort of efficacy of vaccines a little bit, and sort of this is a nice segue into my next question, which is around, with various vaccines efficacy being claimed anywhere between 70 to 90% based on whether you take a complete two set or a one dose for two dose vaccines. Also, with all this controversy around statistically significant, those small risk of sort of clotting with AstraZeneca vaccine. Europe talking about perhaps following up the first AZ vaccine with a second, maybe one of those mRNA. What's your view? I mean, how long the immunity lasts, and can people, is there some sort of recommendation to suggest that people who've taken, let's say in India specifically, Covishield as their first dose, can go for an mRNA or some other vaccine as a second dose? What would be the recommendation here?
So, based on what we know for Pfizer and Moderna vaccines, in terms of how long of an immunity do we have or protection do we have? So the 95% efficacy that we have, what we have seen is based on the data that we have for the time frame, that these vaccines, they will offer protection for up to 8 to 9 months. Beyond that, what will happen, we don't know. And there are actually studies going on right now to look at a booster dose for those people who are going to very soon start to fall in the category of what will happen to people who had the vaccine 6 months or more ago, because we started with December and January when we vaccinated people. Now, at the second, so to answer the second part of your question, at the outset, when we think of all these messenger RNA vaccines that we have, most of them are targeting the same spike protein. So it doesn't seem unsafe if we were to mix and match the vaccine, but a very clear-cut guidance that the Center for Disease Control in US at this point has a statement that the safety and efficacy of these mixed product series has not been evaluated. Now, having said that, countries like France and Germany, they have actually some recommendations based on their health regulators that people who are younger than the age of 55, for the same reasons like you mentioned for the risk of clotting, if they received a first dose of AstraZeneca, they can actually get a vaccination with Pfizer or Moderna after a gap of 12 weeks or so. So this is specific guidance in France, and a similar guidance is there in Germany. I'm not aware of anything very similar in India at this point in time, but I would say that there are studies going on, at least 2 studies. One study in UK that was launched back in February, and they are looking at mixing of AstraZeneca as the first vaccine and then Pfizer as the second vaccine. And there's also a study going on which is looking at AstraZeneca as the first vaccine and the Russian Sputnik vaccine as the second. So hopefully we will have data from these studies in the next few months, where we will be able to give a little more concrete recommendation as to, if the AstraZeneca or one of the other vaccines can be followed by some of the other vaccines, which are also going to become available in India very shortly. From what I see, all of these vaccines may be coming to the market very soon there.
Sure. Thanks, Dr. Wagner. The next question is for you, Dr. Jain. And other than, as a practitioner, I think you have a strong home advantage for this question because your better half is a microbiologist as well. So there's this general perception that that the RT-PCR, which was at one point considered to be the most reliant, the more sort of solid way of determining, right, whether someone had the infection, is no longer as reliable. At least anecdotally, we are seeing a lot of false negatives. And hospitals and doctors are sort of treating people for the infection despite reports coming negative. So what's happening here? What's the most reliable mechanism of detecting infection today, and how should people approach this, given that false negatives are happening?
So if I can break your question into two parts, one is the false negatives of the RT-PCR, and number two is how to manage these patients, those who are false negatives. Now, the inherent the test inherently has some specificity and sensitivity. It is, the sensitivity is around 85% for this RT-PCR, and the specificity is very high, and therefore it is considered to be a gold standard as of now. Now, there can be a lot of issues with the sample collection, with the sample transportation, the sample lying there, and but all put together, it is about 15%, 20% of the patients will have false negative results. Those who are suffering with COVID but still negative. To address these problems, what we do is that we tend to do a second test on these patients. So there are a lot of patients who are negative for the first time, but then they come as positive on the second time. This is one way. The other thing is that we cannot take the patient solely on the RT-PCR, on the face of the RT-PCR only. There are various other mechanisms. The clinical symptoms are there. Their history of contact with the positive patients, that is there. There are other tests like CT scan can pick up these, although I do not strongly recommend the CT scan, but in certain cases when you have consistent negative RT-PCR, then a CT scan can be performed to see if the opacities are inconsistent with the corona or not, with the COVID infection or not. So these are the things which we consider and then start managing these patients. There are few patients, although in my practice also, those who are coming consistently negative despite of a strong indication that that this patient may be suffering from COVID. So there are certain challenges, but as of now, we have the RT-PCR report as a gold standard.
Understood. Thank you. Dr. Wadhwa, this question is for you. We've noticed that actually, before that, there's another follow-up question for you, Dr. Jain. We've seen, a lot of people starting to get impacted with black fungus, right? Maybe news is exaggerating, maybe it's not as big a number, but clearly there is a lot of fear about this. We understand part of it is to do with excessive use of steroids, lowered immunity, elevated blood glucose, but really, what can be done and how do you see this playing out? Do you think this is a small blip? Do you think this is a serious problem, and what can people do?
This is definitely a very, very serious problem, and unfortunately, this is happening in India. I think my fellow panelists, they may not be seeing the mucormycosis in the form and numbers that we are seeing here in India. There are multiple theories that are floating around right now. We do not have a specific answer to this. High blood glucose and overuse of steroids, rampant use of steroids, the use of drugs, the immunosuppressive drugs like tocilizumab, that is one reason. Then there is one theory coming up with the use of the medical grade oxygen versus the industrial grade oxygen that may be contributing to this. Then there is new theory of coming the blood clots in the arteries, in the veins of the nasal mucosa, making it friable, more friable, because the vascular supply decreases over there and making it more prone for the fungus. So all these things are in the form of the hypothesis right now. We don't have a concrete answer to this. Now, why mucor and why now? Is a question that I am looking into and I'm trying to figure out the answer. But as of now, we don't have any answers. We have been using steroids in the renal transplant, in the liver transplant, in the various other disorders, the rheumatoid and vasculitis. Dr. Wadhwa may be using these in nephrotic syndrome and Wegener's granulomatosis, very high doses. In malignancies, the patients are having, but we were not seeing the kind of mucormycosis. in so high number as we are seeing right now. That is, in any case, we had a fair large share of mucormycosis even in the pre-COVID era, right? The incidence of mucormycosis was higher in India as compared to the Western world for whatever reasons. But now when it is going up, this is really worrisome. Now, how to now, as I understand, then we have general population viewing your program also. So let me tell you that if you have stuffy nose, if you have black crusting in the nose, unilateral one-sided swelling, pain of the jaw, tooth, under the eyes, in the eyes, one-sided headache, and in the advanced symptom, if you have blurring of vision or swelling in the eye, these are the symptoms. One must not take it lightly, and they must go and see the physician as soon as possible. The second thing is that in case if there is a problem, then it needs to be addressed very early. Normally, what we are seeing as of now, that the patients who have recovered from COVID, they were in the hospital with the high oxygen, and they were on high levels of steroids when they were discharged. So after 2 weeks to about 6 weeks after discharge is the time when they are coming back to us. Although still we are seeing the patients who were in their who got infected in the early peak. So maybe this time will expand as we move forward. But by and large, people are coming between 2 weeks to 6 to 8 weeks after getting infected. And after getting discharged, they're coming back with these symptoms, and then we are trying to treat them. But this is a real bad news. On top of that, there is a shortage of amphotericin B, which is the mainstay of the treatment, and that is making the things worse. And we do have the capability to certain extent to treat the corona, but in the rural areas, do we have the capability to treat the mucormycosis is one big question. Do we have enough competent ENT surgeons in the rural areas? Definitely in the cities we do have, but in the rural area, that is a big problem. The other thing that I think the epidemiologist in India would be very keenly looking into would be the urban-rural divide. It seems that we have a larger share of mucormycosis in the rural India as compared to the urban India. That is again a problem. And the other problem, very big problem, is the cost of the treatment. Unlike the corona, where you can, if you are infected, you can stay at home in the home isolation, and only a small percentage of patients, they need to be hospitalized. In mucormycosis, I think 100% of the patient needs early admission, early surgery, early amphotericin B to have some, good results. So it is a huge problem.
It is a huge problem, as Dr. Jain said, and the least we can do as general public is be aware of the symptoms, catch it early, make our friends, people we know more aware, so that treatment can be started early. I guess that's probably the most we can do as an aware audience. Thank you, Dr. Jain. Dr. Wadhwa, the next question is for you. And this is sort of also reflected in some of the questions that I'm seeing on the Q&A, as also personally reflect some of my own sort of frustration. I've been tracking development, as have been many others. What started off as a very promising application of HCQ, and then ivermectin, then remdesivir, there have been these sort of drugs and tests which seem to work. They seem to sort of avoid disease getting severe, in vitro versus in vivo kind of issues. But one after the other, many of these turned out to be overhyped, right? No longer recommended for treatment. Unfortunately, some, while globally discontinued, we still continue to go after them like mad and buy them for 30,000 and 40,000 rupees a vial in India. It pains me to see that. But now we are hearing the same about plasma therapy. So the question that I think a lot of us are asking is, do we really understand what works, what doesn't work? Are we still learning? Do we have any sort of solid answers?
That is a great question again. And yes, in this battle against COVID, we are still in a learning phase more than a year into this pandemic. Now, desperate times call for desperate solutions. Some of these medicines have been around for decades, like the Plaquenil, the one you mentioned. We've been using it in lupus patients to prevent flares. Ivermectin, I mean, I literally grew up around this medication in India. Remdesivir, we've been using as an antiviral for other viral infections. And some of these drugs, they got the emergency use authorization for the treatment at some point in time. But the key thing is, when we are doing an emergency use authorization, that means we are looking at a very small number of patients, and the data is really not as credible as we would want it to be. Again, because of the desperate situation, desperate times, desperate solutions. The key to using the medications is to understand the disease process itself. So if we look at the infection with COVID, we can essentially look at it as two different processes, or two processes that play a role. So the first part of this is the early in the clinical course. The disease is primarily driven by replication of the virus, meaning in the first 4 to 7 days, the virus is really multiplying in the body. And then in the second part of the disease, it is really the dysregulation of the immune system, which results in attack on the body and causes the tissue damage. So based on this understanding, if we were to really look for answers, the antiviral therapies would seem to work early on in the early phase, where they would limit the replication of the virus. And all the anti-inflammatory and the immunosuppressive therapies would be more beneficial in the little bit later stages of the disease. Later meaning doesn't mean weeks out, but I'm talking like the first 4 to 7 days for the viral replication, and then with an overlap on that, where the immune system is mounting a response, where we need to calm down the immune system. So that's how we really have to look at it. And, we have a set of medications that are out there, like you mentioned, which, based on very small set of data, were started to put into use, where we are finding most of them actually don't work, and some of them can have very serious side effects.
Thank you. Well, we are a little behind schedule here. This was scheduled for about 45 minutes. We are nearly at the end of time, but I think we're still left with a few questions, and then there's some follow-up questions that audience have. So I'll probably go through selectively some of them really quick, and would appreciate some crisp, short answers from all of you, but this is too important to miss out. This question is for both of you, Dr. Wadhwa and Dr. Jain. We've heard about various equipments being used in context of treatment or management of COVID patients, from BiPAPs to ventilators to high flow nasal cannulas and even ECMO. It would be great to get a very brief assessment, Dr. Wadhwa, from you in how sort of what's been your observations related to the success of these equipment in US, and then correspondingly, Dr. Jain, what have you seen in India? But would request all of us to be really short in your responses, please. Thank you.
Sure. So we learned early on in 2020, what we are seeing in India. We were in very similar situation in April and May of 2020 back here in US. Really, really tight in terms of resources, systems issues, and everything. But in terms of use of this equipment, we really learned early on that ventilators would be our last resort in managing the patients who had COVID. Typically you would start with nasal cannula. As the oxygen requirements increase, high flow nasal cannula became the really preferred way to manage the COVID patients, especially those who needed larger amounts of oxygen, because it would give them a little bit of a positive pressure at the end to keep the smaller lung units open at the end. with the high flow, we saw the advantage. We could still feed the patient. We could prone them much easier than with BiPAP, and the patient could still communicate with you relative to, either the ventilator or having the BiPAP mask on. So overall, it was much more comfortable for the patient, and we saw much better outcomes for the patients, for those who needed very high flows of oxygen with the high flow nasal cannula compared to the ventilator or even the BiPAP. Now, for the, in terms of decision to use the ventilator, it's typically driven, and I will let Dr. Jain talk about it. It's really his area of expertise. But in general, it was driven by, the work of breathing. So if we are worried that the patient's really going to tire out and they're not going to be able to maintain their breathing on their own, and they're starting to retain the carbon dioxide, that's when, the ventilator would be the next step. So, and regarding the ECMO use, I would say the use varied from institution to institution. At our institution, which is also a very huge tertiary care center, so we had referrals from all over. They were preferably trying to do it in younger patients. And again, this may be patient selection bias at our center, but younger patients who were on the vent for less than 2 weeks and they didn't have more than like one organ failure or so. So that's in a nutshell. The high flow kind of came out as the main form of managing the patients, vent being the last resort. And I will stop there for my part.
Dr. Jain?
Yeah, I think I'll pick up from where she has left, Dr. Wadhwa has left. Now, mostly these patients in our practice, we are managing them with the nasal cannula, face mask, and non-rebreathing mask. And the patients are doing reasonably okay with this. The problem and the blessing in this is the happy hypoxia. Even on 15 liters of mask in some other form of illness where the patient is requiring such a high oxygen, they would be breathless, they would be complaining, and they would be gasping for breath. But that is not the case here in this corona for some reason. They are on full flow NRBM 16, 18, 20 liters, but still they are able to communicate and they are sitting comfortably in most of these situations, unless it is terminally ill. Now, when the patient is not able to, or breathless in these circumstances, then the BiPAP comes next, and we try and delay the ventilator as much as possible. This is again unlike in the other scenario where we would, try and conserve the energy and put the patient on the ventilator. Not only it is the reason being the paucity of the ventilator, but we have seen that those who have gone onto the ventilator have done really badly. So that is the other reason that we tend to extend the patients on either on the face mask and NRBMs and the BiPAPs, and try and avoid putting the patients onto the ventilator. As regards to the HFNC, we have had, initially there was a paucity of the instruments and in the hospital, but quickly we got few HFNCs, and we reserved this to those patients, those who are moving out of the ICU and are having a prolonged high oxygen requirement, even in the wards. So that is where the HFNC came handy, and it was very convenient for the patient. As regards to the ECMO, my experience has not been very great in this. The success rate in this particular pandemic has been very discouraging. So we have put the patients on ECMO, and again, the same criteria, the younger population and single organ failure. But I don't think that we have very encouraging result. If you allow me, Raman, can I just ask one word to my panelist, Dr. Wadhwa? What is your experience with the ECMO, and how successful the ECMO was in US?
So again, Dr. Jain, the experience varied from institution to institution. For our institution, it was the CV surgeons who were mostly managing the ECMO. But, the key was the patient choice. But again, I can't say this was something miraculous that really saved the patient. If they really had increasing oxygen needs despite everything, and they are on the ventilator already and they are younger, but we had this glimpse of hope that they would recover because their other organs are working well. That's when they selected the ECMO. We did see patients recover. We did see patients make it out of the ICUs and have good outcomes. But in general, those who made it on the ventilator, the outcomes were not the very best. So I can't give you like in terms of percent or data, but it was being younger patients. Yes, we saw maybe a little bit better chance for them to recover. If we put older patients or those who were longer on the ventilator, we would not have seen that better of an outcome.
Okay. Thank you, Dr. Jan.
Similar to MD. Yeah.
I think we are out of time here, but I think this is a very important topic. I'm getting floods of questions here, people who are appreciating how useful this session is, and they're wondering whether we can cover rest of the topics. I think we are going to take a call here. I know your time is precious, all three doctors. Can we extend this session by another 10 minutes if you have time? Because I would like to continue, and of course, audience can choose. Some of them may want to continue. Are we okay?
Yeah.
This for 10 minutes?
Yeah, sure. We can.
Yes.
Thank you. Thank you. We really appreciate the time. We realize how precious it is. So the next question is for you, Dr. Chauhan, and I'm going to combine this question with many questions that the audience is asking live. The basic question that I had on my list was, what are your words of advice, precautions to take, etc., that you would suggest to a recovered COVID patient? Do COVID patients require any tests to be done post-recovery besides precautions, etc.? I'm going to combine this with a few other questions that I'm seeing people post, and I would request the admin to relay me any questions that might be coming on YouTube. Okay. So one question is from Kunal Gupta. His father feels tired, and whenever he takes deep breath, he still has heaviness in the chest. These are his post-COVID recovery issues. So please suggest if there's something they need to do. On a similar note, Dr. Jan, this is from Prachi Biswas, who's publicly wanted to thank you for saving her husband's life and proactively guiding in all ways possible. And for the audience, for the benefit of all audience, she's asking the same question, which is, it would help if we can hear from you, Dr. Chauhan, and perhaps others can join as well, in terms of what other post-COVID precautions, etc., they need to take. Okay. Over to you, Dr. Chauhan.
Sure. So essentially, I think what you need to do post-COVID is follow the same thing, like, the universal precautions, wearing mask, hand hygiene, social distancing, all those things. Another question which people ask is how long they need to isolate, right? Like post-COVID. So the recommendations here from the CDC are that you need to isolate for 10 days after having the symptom onset. Or you could again stop isolation after 24 hours of resolution of the fever without the use of any medications which decrease the fever, like paracetamol, etc. And once your symptoms have improved, I would just say having a good balanced protein-rich diet would help. Drinking plenty of fluids will help flush the virus out from your system faster. One thing I would not recommend for a general population is, which I see a lot being done in India, is having like waiting for a negative PCR result after having the disease. The recommendation is no longer test-based strategy for general population. I would recommend test-based strategy only for immunocompromised people, just because they shed the virus longer, and it could be, the viral shedding could vary case by case amongst immunocompromised people. even anyone can shed the virus up to like 12 weeks. And at that point, those viral particles are not really infectious. And whatever studies we've had so far, in those studies, another person hasn't been infected with, even if you have recovered from COVID and your PCR is persistently positive, that doesn't mean you're infectious. So I would not rely on the negative PCR result to determine your isolation in general population, because PCR is so sensitive, it can even catch dead viral particles in there. So that would be my advice to everyone. And we follow the same recommendation here, which I just said.
Okay. Thank you. I think the follow-up question here would be, are there other precautions / medication? And of course, I think it would vary from patient to patient, but specifically a question which says, do they need to take blood thinner after they've recovered from COVID, and for how long?
So here we follow 4 things in a COVID patient, along with like a normal complete blood count, CBC, with differential. Then we just make sure the kidneys and the liver is doing okay. So LFTs and KFTs in the beginning. And the thing which we want to get a baseline is a D-dimer, CRP, C-reactive protein, and LDH and ferritin. These are the 4 things we get at baseline. And then we follow them in an inpatient. I would follow them every 48 hours. And when we see there is a trend going up, then we decide about instituting anticoagulation or not. So if the D-dimer is high, then we start the anticoagulation, and then we recommend continuing the anticoagulation for at least a month, even in an outpatient setting when the patient is ambulatory, because here the process of forming the clot is not because the patient is not moving. In COVID, what the problem is that the endothelium, which is the blood vessel lining, that gets infected, and that causes problems for most of the organs. And that's why the clots are formed, because of all the inflammation and the stasis of the blood, which is like slowing of the blood and clot formation. So we just want to make sure that they don't develop like deep vein thrombosis or a clot in their lungs, which is like pulmonary embolism, and which can really lead to increased mortality in these patients. So again, we follow the D-dimer levels in specific patient population, but usually like clinical symptoms are what we follow. So we follow these patients clinically, we see how they are doing, and we also get labs in an outpatient setting. I would recommend labs at least every week, depending on how the patient is doing. Obviously, in sicker patients, we need more frequent monitoring. And based on the labs, then I would go with the anticoagulation,
Yeah, thank you, doctor. So the message for the audience clearly is, do not self-medicate. Do take a doctor's advice on these things, because blood thinners can help, but they can also hurt you if you take them indiscreetly. So be very careful, take doctors.
Nothing is risk-free. So there is always increased risk of bleeding with the blood thinners, especially, in the brain is what we worry about, and a hemorrhagic stroke.
Right. Thank you, doctor. There is a bunch of questions coming on vaccine pouring in as we speak. I'm going to invite Dr. Jan because a lot of these are specific to India, but Dr. Wadhwa and Dr. Chauhan, feel free to pitch in as well. So I'm just going to read out quickly some questions on vaccine. Specific questions: does heart patient have to stop warfarin? And same for patients suffering from thyroid. Do they have to stop their thyroid medicine before getting vaccinated? People with elevated CRP, can they take vaccine or they need to take some precautions? People who are on sedatives or on, let's say, NSAIDs, right? I'm guessing that's what the questioner meant. So he's given an example of diclofenac, for example, right? Can they go for vaccination? Could there be a reaction? Do they need to do something? And finally, someone asks, can someone die after taking both shots?
So, Raman, allow me to take a cue from your previous comment. Do not self-medicate. And I would say this for each and everything, not only COVID-specific things, but even otherwise in your life, please do not self-medicate. And if I may add, do not Google your symptoms. Now, coming to your question, can for all these list of questions that you have posed at me, I think the answer is no. You don't have to stop any medication for getting the vaccination done. There is some specific case of anticoagulation. If somebody is already on anticoagulation for, let's say, the cardiac thing, I think they should go and consult their cardiologist, because the risk is nothing else but except for the bigger hematoma at the site of the vaccination. So the cardiologist is the best person to advise you for how many days to stop these medications and whether you need to stop them at all or not. So this is about this. And die, I hope not.
Okay. I'm gonna play a sort of a pseudo doctor here and skip a few questions which I think have either been covered or perhaps not worthy of your time, doctors. To people who ask questions on efficacy of antivirals and plasma therapy, I suggest you refer to the recording. It has been covered. Can someone catch COVID more than twice? Been covered. Please refer to the recording. I think there are a couple of questions which I'm skipping because they are ambiguous. We will perhaps facilitate offline answering of those questions later. I'm going to go back to the last two questions perhaps in our list, and then I guess that's about it for the day. So this is for you, Dr. Jain. Now, we've seen what we've seen, right, in the last month or two in terms of exponential growth of the cases, and then, of course, with lockdown, a fairly rapid decline in the last few days. We've also been hearing all kinds of substantiated or unsubstantiated reports of the third wave coming, and kids especially being very prone. Don't know how scientific those claims are, but what's your sense? That's one question. Second, I think I'm getting a lot of questions from teenagers here saying, when would we be vaccinated? And unless you do that, how do we even start to go back to school? We are out of school for the last 1 year. So maybe perhaps two questions if you could address. Thank you.
Yeah, so this wave is receding now. How soon it will end and come to the baseline, that only an epidemiologist can answer this. But we can see, we can feel that the wave is receding. The admissions are going down. The frenetic calls to the doctors, they are coming down, and the number of the patients are coming down. The positivity rate of the and I can tell you about the Delhi. I think there are certain other geographical areas in and around, in India. Those are yet to achieve a peak. So they will probably go, go down a little later in the course. So that's about the second peak. Regarding the third wave, yes, there is an apprehension for two reasons. One is that we have seen a clinical shift from the first wave and the second wave. The first wave affected the elderly the most, and the second wave affected, the 30s and the 40s, old 30 and 40-year-old population. And now, having vaccinated most of these, the way the vaccination is going at the pace, and I'm sure the government will increase the pace, and now the new entrant of Sputnik and few other vaccines will be also available in the market. So the pace of vaccination will increase. And now, since we are doing it at 18 plus, the most vulnerable population that will be left unvaccinated would be the kids. So we saw, no problem with the kids in the first wave. In the second wave, we are seeing that few kids are getting sick with this. I'm not saying infected. Definitely, they were getting infected even in the first wave, but now they are getting sick also, and few of them are getting admitted also. I haven't. I have only read some reports of few deaths of young kids also. So now, if the third wave, if ever it hits, then we'll see probably this most vulnerable, unvaccinated population to they will get infected, and I think the policymakers should pay a heed to this, and I'm sure they'll do something before it actually hits us. They should be, at least they'll start vaccinating people or the younger ones, and make arrangements for their treatment if and when this third wave hits us.
Well, thank you, Dr. Jain. I think we've far exceeded the time that we'd asked of all three of you. On behalf of Anon, I would like to thank all of you once again for your precious time and very, very valuable inputs. I think I learned a lot from this session today, and I hope sincerely that my fellow audience did as well. I think we've attempted to cover most of the questions, but there may be a few which are either unanswered, or folks who couldn't ask those questions live. We would encourage them to try and reach us towards to Anon Global Foundation's contact details, and we will be happy to try and get you answers offline. We will also plan perhaps a follow-up based on feedback that we are getting. People are already asking for a follow-up session soon. So I think we are going to bother you doctors very soon again. With that, here's your host, Raman Nagpal, signing off on behalf of Anon Global.